Well, hello everybody. I'm really pleased to welcome you to this research and practice in thrombosis and hemostasis research recap, where we dive just a little bit deeper into the science between what's being published at RPTH. I'm Professor Beverley Hunt. I work in London at a thrombosis and haemophilia centre, and I have had a very long-standing interest in tranexamic acid, which is a major feature of today's discussion. So I am really pleased to welcome from the other side of the world Dr. Zikou Liu, who has been working at the Australian Centre for Blood Diseases in Monash University in Melbourne. Hi there. And he has been working with Professor Robert Metcalf, who we will see later. And he has a wonderful paper entitled Tranexamic Acid in a Mouse Model of Cerebral Amyloid Angiopathy, setting the stage for a novel stroke treatment approach. So I would like to welcome him to give his presentation. If you do have any questions, whatever you are on, whether you're on Facebook, Twitter, or YouTube, please leave comments for us and we can address them to Zikou after he's presented. Over to you, Zikou.
Thanks for the kind introduction. It is my honor to be here to talk about our work on the new approach for treating cerebral amyloid angiopathy related stroke. The main focus of my presentation today would be using a mouse model of CAA to study the long-term effect of TXA treatment. Here, I'd like to use a figure adapted from a review to illustrate the reinforcing cycle of CAA and hemorrhagic stroke. The amyloid precursor protein is produced by neurons and cleaved into A beta, which is usually cleared by the perivascular drainage. Once the amyloid accumulates in the blood vessel wall due to various reasons, this deposition would then progress into CAA, which induce the vascular injury and increase the risk of hemorrhagic stroke. The more concerning issue is that the vascular compliance is believed to contribute to the A beta deposition per se, thus the recurrent bleeding seems unstoppable. According to a meta-analysis on 70,000 subjects, the prevalence of CAA in ICH patients is over 50%, and currently there is no treatment for intervention. Our lab is studying on the role of fibrinolytic system in the hemostasis, and we proposed a possible linkage between the damaged blood vessel and the locally hyperactivated fibrinolytic system because of CAA. Please let me illustrate the rationale here. Plasmin is the main protease in charge of fibrinolysis. However, shown by previous studies, plasmin can also be generated on the surface of amyloid beta in a lysine-dependent manner, and in turn, it would degrade the deposit just like lysine the fibrin clot. Yet plasmin is a double-edged sword in the hemostasis system. It can activate downstream proteases like MAPs, the complement pathway, and a few other factors. All these would increase the BBB permeability, which brings the risk of hemorrhagic stroke. Tranexamic acid, TXA, is a lysine analog. It is widely used in clinical settings where bleeding is unwanted. We proposed to use TXA to block the amyloid-driven generation of plasmin so that to prevent such bleeding in CAA. Due to the chronic nature of CAA development, the treatment to prevent a CAA-related hemorrhage needs to be long-term and ongoing. There are some pros and cons. First of all, TXA is widely used in many clinical scenarios as an antifibrinolytic reagent. Its safety profile has been well acknowledged for the short-term usage. TXA is usually given via IV injection. On some occasions, it can also be taken a tablet via oral administration, namely cyclopentone tablet, used for treating tooth removal bleeding, nose bleeding, and heavy menstrual bleeding. Apparently, we would prefer oral administration for long-term treatment, which is the way we test it. Last but not least, TXA is affordable. It only costs around £1 a day, which again meets the requirement for long-term treatment. As for the potential drawbacks of using TXA, besides that, the attenuated thrombolytic system might increase the thromboembotic risk, and the TXA has been reported to be able to trigger seizure in the brain at a relatively high dose. The most relevant concern regarding to A-beta deposition is that there might be extra accumulation of A-beta in the brain due to the barrier clearance pathway. The one previous research indicated that the A-beta level did not increase in plasmin deficient mice. We need to address this doubt more carefully. Therefore, we examined the long-term TXA treatment on mouse model that developed CA condition to see the actual outcome. So firstly, we studied the biodistribution of TXA following the oral administration. We gave wild-type mice TXA in drinking water for 2 weeks and collected some organs to measure the TXA level by mass spec. This data revealed that TXA is accumulating in all the organs are collected. It was most prominent in the kidney, while less in the lung, liver, and spleen. Notably, TXA level in the brain was significantly less while remarkably consistent. The y-axis here shown is in log scale. The accumulation in kidney is expected as TXA is mainly cleared through the renal system, and this suggests that the normal kidney function is essential for TXA treatment. And the tight control of brain TXA level is most likely due to the BBB regulation. The mouse model in our study is the APP-PS1 mice, which overexpress human amyloid precursor protein and a mutated PS1 in their neurons. This image here from another study shows that the amyloid beta accumulate on the blood vessel wall, which would result in CAA. These 2-photon microscopy images were taken from an APP-PS1 mouse brain studied at 6 months old. In fact, the A-beta accumulation in brain can be detected from 6-week-old, and a cognitive deficit emerged from 8 months age in these mice. We included the APP-PS1 mice and their wild-type litamate in this experiment. These mice were given TXA or placebo in drinking water, starting from 2 months and last for 6 months, which is equivalent to a 20-year-old human aging to 50-year-old. We chose this treatment time window based on the assumption that the drug effect, if there is any, would be most obvious during the accumulation phase of A-beta. We euthanized the mice and collected the plasma at the end of the treatment to check if TXA can actually block plasmin generation, therefore can prevent BBB damage. The TXA level in plasma is around 0.5 microgram per ml. And the plasmin activity assay shows that for both phenotypes, plasma from TXA-treated group is less potent to generate plasmin compared to the placebo-treated group. Therefore, the expectation for TXA to block plasmin generation is achieved. We then evaluate if the long-term TXA treatment brings extra A-beta accumulation. We collected the brains from APP-PS1 mice mentioned above and did immunohistochemistry staining against the human amyloid A-beta. One wild-type brain is included here as a negative control. The figure below is a positive sample. The brown particles represent the A-beta plugs. These images were analyzed by ImageJ, and we quantified the A-beta deposit both on the particle count and the total area of brown staining. The result indicated that there is no increase of A-beta caused by TXA treatment, either by area or number count. As the brain A-beta level is not increased by TXA, we would not expect a neurological dysfunction to be exacerbated either. Indeed, when we proceeded the behavior test, including wire-maze test and the parallel road floor test on these mice during the 6 months treatment, the result altogether suggests that by the time of the experiment, there is no exacerbated neurological dysfunction in the cohort treated by TXA. So, in conclusion, our animal study shows that the 6 months TXA treatment via oral administration can suppress plasmin generation, and it does not increase the A-beta plaques in the central nervous system. It does not exacerbate the neurodegeneration. All above suggests that TXA is a promising approach to prevent the CAA-related hemorrhagic stroke. For future research, as the CAA-related hemorrhage phenotype would usually emerge after 8 months age of mouse, the treatment after that time point would provide more insight if TXA can reduce the risk of hemorrhagic stroke. I'd like to thank everyone on this slide, and thanks to this recap. Also, I want to thank to the technical support and our collaborators. I'd like to declare there's no conflict interest with this work. Thanks.
Well, thank you very much, Zikou. Before we extend the conversation out, I just wanted to ask you, you also looked at some proteomics, looking at inflammatory markers. Did you want to just describe what you did there and what the results were?
I think you're talking about the O-links, the O-link
Yes.
experiment. I think So we use a technique called O-link to test the proteomics change in the plasma. So we found two proteins that are altered either by the TXA treatment or by the genotype. So most significantly, the change by TXA treated APPPS1 cohort is the reduced epicam. So another protein is actually elevated in the TXA treated wild type. We don't really know why. It is the CCL20. So we just identified this protein being altered in our long-term treatment. I think Rob will give more information about the O-links.
Yeah, you did actually look at 92 markers, and yet you only had 2 that showed any change. So statistically, one might expect a few changes that may not be entirely real. So all the other inflammatory markers were not affected. Is that right?
I mean, that 92 panel, the biomarker panel, is including TNF and IL-6, things like that. And I mean, honestly, we were a bit surprised that these inflammatory markers were not impacted. I mean, our expectation would be TXA will do something about them, but at our end in this experiment, we didn't really pick that up. Yeah.
Okay. So really, you're doing a study looking at the safety of TXA over a 6-month period, wasn't it, in the mice? And it looks like it was very safe.
In regards to the accumulation of A-beta, yes. Yeah.
Yes.
I mean, at least it did not do the unwanted thing. Yeah.
Okay. Okay, so at this stage, I'm going to bring in two other of the authors. So Professor Robert Metcalf, who needs no further introduction, very well known in thrombosis and hemostasis circles, and also Dr. Geoffrey Cloud, who is a neurologist, formerly from the UK and now working in Melbourne, and obviously key in this study. Before we move on a little bit, I wonder, Jeff, if you could tell us just a little bit more about cerebral amyloid, because I keep coming across it in my clinical practice, but not everyone does. Do you want to tell us a little bit more about the epidemiology and the problems associated with it clinically? Thank you.
Yeah, thanks, Beverley. Well, if you haven't seen it in clinical practice, you will do. Essentially, certainly in a secondary care setting, it's one of the commonest causes of intracerebral bleeding. So overall, in terms of all stroke, around about 12% is rated intracerebral hemorrhage in developed countries, and we think at least half of that is related to cerebral amyloid in terms of pathology. And in terms of diagnostic criteria, the advent of MRI has really changed the game now. We've got a lot of good biomarkers with MRI phenotyping, and it seems to really occur generally in terms of the sporadic form over the age of 50, although there's great interest in iatrogenic CA, which is a whole different topic of conversation. But in terms of the clinical manifestation, in secondary care, we see people with classically lobar intracerebral hemorrhage or non-aneurysmal subarachnoid hemorrhage, or occasionally they can present in the TIA clinic with transient focal neurological episodes and MRI imaging showing the hallmarks of CAA with increased or enlarged perivascular spaces, small white matter ischemic lesions, multiple cerebral microbleeds, superficial siderosis, and areas of potentially silent lobar hemorrhage. So these are all sort of the clinical phenotypes. And as Oscar said in his talk, we don't have any treatment for patients at the moment. It's a pretty hollow conversation in stroke prevention terms in clinic. There's been subgroup analysis of large cohorts of stroke patients where blood pressure alone seems to be helpful, but many of the patients in my experience do not have high blood pressure. So you're talking about lowering normal or low to normal blood pressure, and just avoiding things which may provoke bleeding. And certainly one of the commonest clinical conundrums is whether patients should take antithrombotic treatment for other reasons. So we're in a very difficult place, and this hypothesis, which we published in Stroke, the American Heart Journal Stroke, was a collaborative one with myself and Rob and some of our Australian colleagues, as well as some people in the UK, David Waring at Queen Square and Hugh Marcus in Cambridge.
Well, thank you. And I must say we have an MDT actually on a Monday quite often, and we discuss those patients who have cerebral amyloid who have atrial fibrillation. What are we going to do for them? Because we can't give them a DOAC, and we have a atrial appendage ablation program. So we're picking out the ones who've got bad cerebral amyloid. So it's a frequent problem. So let's come to this amazing hypothesis that TXA may have a new life in preventing bleeding in cerebral amyloid. Rob, where did it come from? Was it what happened?
Well, the idea.
Yes, where did it come from? Was it from your head or was it a group think?
Well, it's a long story how I presented this idea to Jeff, but I won't go through that with you right now. But no, it's been known for in the fibrinolysis field. It's been known for a long time that amyloid can drive plasma generation in exactly the same way that fibrin can. And as some of you may know, or the aficionados in the fibrinolysis field would know, is that the system that we refer to as fibrinolysis is actually a broad spectrum system which removes unwanted proteins in general, of which fibrin is just a subset of that. So misfolded proteins, the amyloid, fibrin, are all cleared by mechanistically the same way, through plasma generation. And then whatever target you're looking at, fibrin, misfolded proteins, or amyloid, plasminogen was already known to engage to lysine residues on the surface of those proteins. So it seems reasonable to me that in a situation where you have an amyloid buildup, that will provoke plasminogen generation in exactly the same way that fibrin buildup promotes plasminogen generation, and it's been generated for the same purpose. In fibrin lysis, that is to remove fibrin. In amyloid doses, that's to remove amyloid. So, and since it's all lysine dependent, it's been proven many times over that tranexamic acid can stop the binding of plasminogen to amyloid. It seemed quite reasonable to me that you could use tranexamic acid as a lysine analog to stop the amyloid-driven plasma generation. And then I had this discussion with Jeff a few years ago, just letting him know about this biology that Jeff wasn't aware of at the time. And I said it to him, I think you could consider tranexamic acid in this condition. And Jeff got very excited, and after a little bit of arm bending, I think he got familiar with it and got very excited about the possibility. And then we wrote that article in Stroke a couple of years ago as a hypothesis. And then Zikou and in the lab, we decided to, well, let's test it. Is the drug relative? Could it be? Is it safe? Because anyone on this who would have this condition would basically be needing to have this drug almost for life. So, you know, the long-term prospects are obviously, it's a long-term story. And as you know, Beverley, tranexamic acid is generally safe, but it's mostly used in the short-term setting for a day or a week or not much longer. In this scenario, it's months or years, and we don't know what that long-term treatment would be. So I know a lot about what happens when you give tranexamic acid to humans or mice over the short term. Lots of inflammatory markers are changed because plasmin also has a role in controlling inflammatory processes and immunity. Certainly in the short term, we know that. We've published that, as well as many others. But you know, the long-term effects on these paradigms, I had no idea what to expect. And what Zikou followed up in response to your question about the inflammatory changes is very important, because it seems to me that the long-term treatment of tranexamic acid does not seem to have any didn't have the inflammatory profile that I may have expected to have. It seems that the host, in this case the mice, adapted to it in a way that the inflammatory system stabilized. And of the 90-odd markers that we looked at, which are very well-known inflammatory mediators, only 2 of them were slightly altered. So I was quite pleasantly surprised to see the lack of any outcome there, which was, again, also very encouraging, in addition to the lack of change on A beta levels, which is the primary purpose of the study, really. I think I answered the questions at once then.
So Zikou's done this lovely work showing it's safe in mice. How are you going to design a trial in humans? How are you planning to go forward, Jeff?
Yeah, thanks, Beverley. I mean, I think, as I've already intimated, in Stroke Clinic, it's a very empty conversation trying to diagnose people with cerebral amyloid and then what next. So I think what we have decided that we'd like to take a look at is focus on people who've had symptomatic cerebral amyloid events, in particular lobar hemorrhage, and offer them entry into a safety and feasibility study in the first instance by randomizing them to oral tranexamic acid or placebo, and I think we'll probably do it over 3 months. I'm saying the protocol at the moment is in draft form, as I mentioned. I'm collaborating closely with my colleague David Waring at Queen Square around this, but the idea would be to look at particularly for thrombotic complications in this cohort, and then we would do MRI imaging entry and also at intervals looking to see if there's any signal of efficacy, and probably follow people for 12 months. So broadly speaking, I'm not sure how much further we can take this in the lab now. There's we presented this work to the Kraft group of the International Cerebral Amyloid Angiopathy group, and there's generally a huge unmet need for a treatment, and it's generally met with enthusiasm. So, I mean, the main issue, though, tranexamic acid has been around for a very long time, as well. You know, Beverley, there isn't a huge amount of data on people taking it orally for long periods of time. As Rob intimated, it's like most secondary stroke prevention. This is a long-term preventative treatment, so that's where we're into the unknown. But a randomized placebo-controlled trial in patients for at least 3 months to start with, looking for safety and any other issues with feasibility. But I think the feasibility, just from a clinical point of view, is not going to be difficult because patients are desperate to try and take something to cheat nature in this situation.
Very good. Very good. Does anyone have anything they want to add to this very exciting development for TXA?
I might want to just highlight that in this experiment, we treat the mice with TXA at actually a very high dose. And
Yep.
I mean, we do that because we want to see if that high dose would actually cause anything. But eventually, I mean, this dose, they actually each mice, if they consume 4 meals drinking water a day, then they're actually taking 80 mg of TXA a day. So, which is a very high amount. And eventually, after 6 months, it didn't end up with anything worse. So we're very glad to see that.
Will you be doing a dose escalation study, Jeff, in your safety study?
It's a good. I think Rob will be able to tell us. Have got a good idea of what oral dose will suppress fibrillar activity, and I think the main issue is probably having. I think, you know, it's renally excreted, so most people, we hope, will have normal renal function, but we'll probably have 2 levels of dosing depending on GFR. I mean, I think if people have got anything approaching any other than mild renal impairment, we probably won't put them in the pilot study. But we weren't going to do a formal dose escalation, but we could consider that. But I think the dose is about about a gram TDS. Is that correct, Rob? I think that we were going to aim for. So, and they come in 500 milligram tablets in Australia anyway. And as Zikou says, it's cheap as chips over here. So $6 a month. So £3 a month we can get the treatment for.
So, Rob, what are its inhibitory kinetics when you look at its effect on amyloid and compare it with its effects in the blood? Is it very similar? It's exactly the same, is it? Really helpful. Okay.
It's the same.
Okay.
It's the same mechanistically. It's identical. I mean, amyloid has an array of lysine binding, exposed lysine residues on the surface, as does fibrin, and tranexamic acid it stops the binding of plasminogen to those sites and stops the plasma generation. The kinetics are interchangeable. We published this. Well, we did the comparison with misfolded proteins and fibrin some years ago, and others have done the comparison specifically with amyloid. So you don't need to, as far as I'm aware, you don't need to boost the level any higher than what you need to do to stop normal fibrinolysis. Right.
Amazing. Okay. Well, I think I'm going to wrap this out now. I found it very exciting. Thank you, Dr. Liu, for your wonderful data. And thank you, Dr. Cloud and Professor Metcalf, for your great input. And we're all looking forward to seeing your trial starting and hearing the results. So hopefully sometime next year or the year after. Hope so. Anyway, so thank you.
It'll be that sort of period, yeah.
Thank you, everyone who's joined us online. This will be available later as a recording, and please spread the word. Thank you, and good night from me, and it's good morning from them.
Antipodes.